throughout this 2-day symposium. And Prof. Rainer Sauerborn and myself, we agreed to play piano by Claude Debussy. And this is the piece, it's called Children's Corner. I will play the first part, and Prof. Rainer later after lunch will play the last part, the sixth part. So I hope you enjoy it.
Wow, wonderful. Okay, thank you, Professor. Wow. It's time for our next session in the symposium. The topic for the next session is climate change and non-communicable disease. As in the first session, there will be some prominent speakers presenting the issues covered the topic. And to guide this session, may I invite Dr. Revati Palhe to be the moderator. To Dr. Revati Palhe, please.
Welcome everybody. I hope that you've had a very nice coffee break. And like Yodi said, that it's the winds of change will move slowly from Indonesia to the rest of the world, and music is always a very good start. So with this, I would like to welcome you all to the second session, and I would take the pleasure to introduce two of our eminent speakers, and I invite them to join me here. The first is Professor Rhino. He's the director of the Institute for Public Health at the University of Heidelberg. He is also a medical doctor by training and a pediatrician by specialization, and one of his essential hats, I would say, is that he's heading the chapter. He's a chapter head in the next IPCC report for climate change. And the other hat that he wears here today in Indonesia is that he is going to lead the inter-university collaboration for Centers on Global Health, IUCGH, which we are trying to establish through the Depth Swap 2 collaboration. So welcome, Dr. Sawa. And I would also like to welcome Dr. Hari Kusnanto. He's a lecturer in the public health department at the Faculty of Medicine, Gajah Mada University, and at the same time he's also head of the Center for Environmental Studies, and they are both going to talk to us about the health impacts of climate change, particular focus on non-communicable diseases. So thank you. And, maybe Rhino, you can start.
And from far away, dear students, it's my pleasure to be here. It's my second time, and it gets better and better, and I like this place, and I like this country, and I like the university and the collaboration. So let me share with you some thoughts, not only about NCDs, but also on how we articulate, how we implement this topic in a university like Gajah Mada and partner universities, and this in collaboration with a university from Europe. And as you see here, I'm the head of the Institute of Public Health, but I'm also proud to be the guest professor of Global Health and Climate Change. Believe it or not, there's a guest professorship at the Arctic Circle in Umeå in northern Sweden, and I'm very happy to have this assignment. Now, I'm told that not all of you... This doesn't work? Oh, it does. Just the wrong direction. Not all of you know this inter-university consortium on global health, I'm told. This is, I think, a major step in the move towards global health, towards integrated health research in Indonesia, and it comprises a consortium of 5 universities. One is, and the leader is Gajah Mada University, then Andalas University, Diponegoro, I have to read this because they are very difficult, your names, Mullah Warman University, Sudirman, and Gajah Mada, of course. So these 5 got together and they have created and started and launched this consortium a couple of months ago here. I was also here, so this is a new kid on the block. And they have chosen, and I am supposed to be the partner on the German side, and there's a consortium on the in Germany as well, who is kind of collaborating with them. Now, the 2 topics that you chose were very timely and very well chosen, I think. Oh, will I make it? Yes. Non-communicable diseases, and this is why I'm here. And then the other topic is climate change and health. Now, these look like completely different animals who have which have no interrelationship, and that's exactly what I want to. I think I have to do this direction, or there. Do they have anything together? Is there any link, or are these just parallel silos, as Yodi says, silos that just live in parallel work? One works with meteorology and the other with cancer and with cardiovascular diseases. Let's see whether there are these links. It's really... So, before I go further, you have to understand a little bit about the concept that we use in climate change research, and I only give you as much introduction as is necessary to see where the links are. First of all, there is finding out what is the health impact of climate change. That is not easy. It requires a lot of new methods, and we want to find out what proportion of the given disease burden on a country, on a population, is increased, is deteriorated by climate change. Some are improved, but they are really small, this number of these diseases, in terms of their severity, in terms of their incidence, in terms of their case fatality. So, in the absence of any additional measures, so if the world was sitting on their hands waiting for climate change to come, which disease would change how much in which respect? That is called health impact research. The next one is adaptation. Of course, this world and the health system is not waiting for being impacted by climate change, but there are a lot of possible things we can do. We can foresee, we can see which populations will be impacted, how much, when, in which disease, and what can we do. Surveillance, early warning, can we have disease-specific interventions, and so forth. That's adaptation. Maybe you have a new battery, because it's now at 6 pushes to get it. Oh. Mitigation is what we medical people would call prevention. Let's reduce emissions of climate greenhouse gases so that the problem is not arising, or is not arising so much. That's mitigation. And then comes 7. Yeah. The health co-benefits. Do you have another one? The health co-benefits of mitigation. In the meantime, I can say next slide or something. I think this needs a fresh battery. Thank you. So that is an important concept. That means if you do something because you want to change it, you want to save the climate, you know, these big conferences, they decide you should have, let's say, more bicycles in towns and eat less red meat and so forth, red meat. That rings a bell to you, because then there are also co-benefits for health. You do something for the climate, but you also get healthier. So the slogan is, what's good for the climate is good for you. It cannot be applied everywhere. It's good for your health. But there are areas where you can really say there are health benefits if you do climate policy. And this is in the realm of NCDs. And we will see this in the next slides. Next slide, please. Okay, now this is just a concept slide, very simplified. You see, we have a baseline burden of disease on Yogyakarta population. And we assume it doesn't decrease, it doesn't increase by the end of the century. It's also simplification. And then we assume that the climate change will increase that burden. The slope is not scientific, it's just illustrative. And it's also not linear, but it's just for the thinking. The next click, please. The co-benefits can nibble into the baseline burden of disease. That means by doing something for climate change, by completely different ministries, completely different people, we will have a smaller slice of basic burden. Maybe NCDs. Of course, not as big as this, so don't take these slices as proportionate or something. Just a think piece. So here we can nibble and we can have a positive health impact, although it was not meant to make you healthier. Then, if you do mitigation policy, not only do you reap health benefits, but you make sure that the temperature increase doesn't get as high as that, so the health impact will not be as high as that. So that one can be reduced, the maximum health impact can be reduced by it not getting as hot and not getting as extreme in weather events as it would have in the absence of climate policy. And the next slide is adaptation. Let's look at dengue. That's the easy thing, and you have it here. There are models that can predict dengue epidemics 3 months ahead of the epidemic. By the way, developed by a doctoral student in UMU from Malaysia. That gives a Singaporean and the Malaysian government a lead time to enforce and to improve to step up, I should say, their control measures. They can't do it all. Even Singapore can't do this always because it's too costly. You have to visit every house every day and look at all the water pots and so forth. But for this time window that was predicted based on climate models, they can. So this is a disease-specific adaptation measure. So this one can nibble into this potential impact at the end as well. So in the end, what you have is a net health impact, and you have also something saved here. Do you understand this? Just a concept where we can reduce the negative health impact of climate change and where we can gain, particularly in NCDs, with the co-benefits. I will elaborate on this. So the next, please. Now, this is the standard slide which shows how things move from the driving forces, that is our industrialization, our using cars, our using cement factories and so forth, our cutting forests and so forth. Greenhouse gases are produced, climate changes, and climate change is not only temperature. We should not talk about global warming, although warming is a part of it. It is extremes, and that country knows a lot about extremes, even in the absence of climate change, meaning floods and mudslides and hurricanes and so forth. Temperature, precipitation, these are the variables that are summarized as climate change. Now they have direct effects on health.
Sorry, Professor?
Yes. Yeah, but do I get my point? Okay. Direct ones, if the heat wave, let's say there's an elderly, frail, comorbid, diabetic person who has unfortunately a higher propensity to die in a heat wave than the rest of us. So that would be a direct temperature-related death, you know. Or somebody's killed in a flood. That would be direct. Most of the health impact is mediated by other factors. For example, microbes, malaria, you've heard about this from the press, dengue and so forth. Or food systems, also important for this country. There will be changes in harvest yields, rice, maize, corn, maize, and so forth. And of course, other factors. And then you have a list of diseases, of group of diseases. Air pollution related, that's COPD, another NCD. That's asthma, another NCD. Water and food-borne diseases, that's infectious. Vector-borne, infectious. Food storage, and then comes mental, nutritional, and other health effects. Mental should be a non-communicable disease, but it isn't, according to WHO, and I will come to this big question mark later, in my view. And then other NCDs. So you see already from that graph that NCDs, although they are not in the press, they are not researched with regard to climate change to any reasonable extent, they are all over the place. And the question is to get this delta, and that would be a very nice work for doctoral students or postdocs to get a handle on how much of this burden which is there anyways, there is dengue, there is asthma, how much more do we get through climate change? And if you click one more time, Okay. And to do this now by vulnerable group, location, urban, rural, by economic status, location, time, when does it happen, and so forth. So that is basically find the impact. And then the adaptation is here. Also, research is needed how to do it. What's the best cost-effective measure to prevent the additional burden? Then you have the co-benefits. Because you do mitigation, you get better health. That's very bumper sticker-like, but you know what I mean. Okay, you have this, and my presentation should be hopefully on that CD. You can look it up in peace and quiet at home. Next, please. Okay, one back. So these are the ones where you have NCDs. So one is surprised to see these things, and this is from 2009, modified it a little bit, and there are maybe 5 publications on NCDs and climate change. Make that 6. And if you look at infectious disease, nutrition, you have maybe 500. So there's vast disproportional interest of the scientific community, once again, which is not proportionate to the burden of disease that we anticipate. Next, please. Just to make that very clear, there is no climate-specific disease arising anew, falling from the sky, and you can see, okay, 4 people in the room have a climate disease because they have yellow or green stripes on their, in their face. I can see them. No. Everybody has the disease they have, and some of us, will get a little bit more of it. So that's the red tail here. That's also a schematic graph. Don't take the size of the bars for granted. So here you have the infectious diseases, and everyone gets a little one on top. Not everyone, but about 80 diseases are climate sensitive on the planet. Then you get the injuries and drowning. There are earthquakes anyways, there are cyclones anyways, but they are increased, so you get this. And then there's NCDs, asthma, heat stroke, you get a little add-on. So this is what we call of impact, all the reds together, if you like, impact of climate change. Next, please. Now somebody, and that's a group in Australia, and they are very ahead of the pack in looking at climate change. Tony McMichael, the person who wrote, who designed this previous slide, or the previous but one slide, is the leader in the field. He established the field climate change and health maybe 15 years ago. So he works with George Hellstrom and Ruth Bonita. Some of you hopefully know. She's also from Australia. So he came up with a concept how NCDs could be triggered. What are the factors intervening between heat signal and an NCD? That's very kind. So here we go. Local climate change, heat exposure at home or at the workplace. That many NCD people suffering from NCDs cannot cope very well with heat excess for various reasons. Then we have air pollution, ground level ozone, you know, sunlight, temperature, diesel exhausts, some volatile organic components, and particulate in the air, the dust in the air, conjure to create ozone, which is very bad for your bronchioli, so asthma is triggered. And then you have pollen. In many areas, you have a longer season for flowers to flourish. So you have allergies, you have asthma. Food scarcity, you have malnutrition. I would count malnutrition among the NCDs, although WHO doesn't. Extreme weather and sea level rise, injuries, this is another thing. And then there are toxic issues when you have flooding or when you have higher temperatures. Let's say you are in a shoe factory in Vietnam and you glue the soles to the shoe, and with higher temperatures these solvents are more in the air and you get also affected. So he listed a couple of these intermediate exposures that then lead to heat stress, dehydration, kidney disease, cardiovascular, respiratory, then malnutrition, of course, on child health, injury, which is not, of course, a non-communicable disease, and then some bits of poisoning. And then you have an added effect on morbidity, mortality, and that's Tord Shellstrom's very strong message also on work capacity, but that's another story, another lecture. Because it gets too hot, people cannot work in the lunch hours. They have to start early, break, come back. In many countries this is already happening. Farmers and factory workers. There's only 0.5% of all factories in developing countries is air conditioned. So this is a huge issue of economic development which I'm just mentioning but not going into detail. So what do we need if we want to research this? We need to have good data on population, because these diseases start not in the hospital. They start in the population. People collect risk factors. Risk factors are developing into real disease and so forth. And if you like, climate change is a risk factor of NCDs. Another one. So if you want to do research, you want to have very good population-based data. And I think Siswanto is in the room, or he's coming. Is he not? Not yet. Okay. So you have very good population-based cohorts in this country and elsewhere. We can use them. Then you have to identify the risk factors of NCDs and now of climate change, which is weather, models, trends, and so forth. This is here the climate. And then comes the disease, and if you like, you have these arrows from both sides that conjure to generate NCDs. So this is a little bit the framework of a data set that you need from meteorology, from the population, collecting risk factors and collecting disease information in order to tease these things apart. Now let me just open a little parenthesis. Nobody has really defined NCDs today, and WHO hasn't really. They are talking about the major ones, that's the big four. And that are the ones that are in your concept of the Consortium for Global Health. I think with a reason, but we should not forget that this is a selection. Are we committing the same mistake for malaria, tuberculosis and AIDS, neglecting other important diseases? I just want to throw this into the debate. Of course, there's a logic, because they are all linked by similar risk factors. So if you combat one, you improve the outcome of all of them. And that's smoking, salt, fat, physical activity, sugar. And so there is a set of risk factors. Some call it 4x4 if they regroup this differently. That makes sense, but what about mental health? I mean, with the progression of aging populations, how can you exclude mental health? So NCDs plus mental health disorders. If you go to the website of WHO, they say this is NCDs, but then they say immediately, but this is the most important one. And then there are many others which you leave out. So I would suggest that we, for the purpose at least of this presentation, talk about all NCDs. That means all diseases that are non-communicable and chronic. Of course, including multiple sclerosis, Parkinson, malnutrition. Of course, I realize, and this is why I have made it so small that nobody can read it. Of course, HPV is causing cervical cancer. Of course, hepatitis B virus is causing liver cancer. I know that there is an overlap, and I fully agree with Yodi that we shouldn't be too parochial here and there. But if we talk about NCDs, we should really know which subset we are talking about, or whether we talk about all those diseases that qualify as NCDs. So I would go for the last one for the purpose, and I would invite you to debate whether it makes sense to exclude mental health, for example, or any of them. So now we just go down the list. Climate change, there's a two-way relationship, and I will do the next thing as well. So they can increase the incidence and the severity. They can make things worse. That's what I said so far. But they can also increase the vulnerability of patients. If you are diabetic, you have hypertension, you live in the upper apartment in the Paris home, you had a much higher likelihood to die of the heat wave than if you had no pre-existing conditions. So people with NCDs are more vulnerable to die of climate change. Climate change makes specific diseases worse. These are the two groups. Yeah. And now I have some examples here. The most important ones that are directly impacted by climate change is asthma, pulmonary constructive oppressive chronic obstructive pulmonary disease, allergies, and you read them: cerebrovascular, cerebrovascular stroke, multiple sclerosis, renal failure. You would not count this as an NCD in the Big Five definition. Chronic malnutrition, a big consequence of climate change. That I'm working on the health chapter of the IPCC report, and malnutrition figures in the first row of health consequences. If we use the narrow definition of NCDs, that is how many minutes do I have? 5. Okay. That it would be a disaster. You would then exclude them. Mental disorders, also very big. Now, those with pre-existing NCDs who die for other reasons, because they are frail, they cannot move, they need drugs, there's a power failure, they don't get their insulin and so forth. That's diabetes, hypertension and so forth. People with reduced mobility, the elderly, and cognitive impairment, mental disorders, and patients with renal insufficiency because they cannot cope with dehydration very well. You know that that is a very common presentation of how NCDs develop, and at the minimum you could add now climate change as one of the environmental factors. That's taken from a publication. I'm sorry, I should have given the source on non-communicable diseases. At the minimum it's a risk factor, but it also reduces the coping capacity, particularly with heat, of people with pre-existing conditions. This one is a table. I would invite you, and I have asked to give you a handout of this paper, because I have a couple of tables from this paper which I cannot possibly run through. But you see, for example, increased, I would just take examples now. Increased temperature and less rainfall leads to higher ground level ozone and more pollution, air pollution. That leads to CVD and so forth. By the way, all this is not undergirded by hard research. I am ashamed to say that the world has not bothered to do research on this, so it's an invitation to all the young, brilliant minds here to go into this field. It's very plausible, physiologically almost cries out for this, but it has not been corroborated in good studies yet. So let's look at this. And yeah, so this is what the IPCC says will happen to changes in PM 2.5. These are the dust, fine dust in the air, and to ozone. And ozone is red. Parts per billion is here. Yeah. So this is microgram. This is the fine dust, and this is the ozone. And red is getting worse and blue is getting less. And it doesn't take Einstein to find out that there's a lot of red here and here and here and here. So these are different models, but the message is clear: there will be a lot of more of this pollutants. What does it do to health? Oops. Yeah. So here you have Southeast Asia, all measures, and here you have Southwest, North America, Latin America. You see that in that model, given that the development air control, clean air control is working, you might counteract this trend and you might get fewer premature deaths here. But this is only if you control your air. If you leave the climate unchanged and you don't control your air, this will happen. And you see here a clear ozone versus increase in mortality. You see that the more you allow ozone to increase, the more you get an increase in the mortality risk of the population. So if you don't do anything, that's going to happen. The model assumed, the previous, assumed that these countries would get richer, would control their air and so forth. Heat stress is the next. I want to give an example. That is the famous heat wave unfamous, I should say, in France, where more than 40,000 people died in excess. And you see the temperature here, and you see the death cases here. Now, who died? And that is my second point. It was the elderly, it was the frail, it was those with NCDs who died. And here is a French publication, and it says, here's the elderly. Look, this is the number of elderly above 75 who died. Look at the others. Both females and males. So a heavy surmortality of the elderly, and there are papers that show which diseases they suffered from, and they had diabetes, hypertension, and so forth. So they were, and they lived, they were also the poor. So there's an equity issue here. They lived here, in the upper, under the roof, where it's very hot. This is a view, an anthropologist has gone back to the apartments of the people who died, and said, why did this person die? Imagine this is an immobile person with multiple sclerosis. I mean, how is he going to or she going to move? It's hot under the roof, so it's not by chance who dies and where they are. And this is a study from Burkina Faso, now a very low-income country in West Africa, that shows also that the elderly, we haven't done an analysis by disease yet, that the elderly die more often if this is 30 degrees, 35 degrees, 25 degrees, 10 years of retrospective data, and you see as temperature gets higher, there's a steep increase in the risk of dying. So we see a similar, why should it be different? We see a similar effect of heat on the elderly in Africa as we see in Paris. That is global health, really. So I summarize this because it was maybe a bewildering tour de force through this subject. So health impact of climate change increases the burden. I showed this to you. Adaptation, I give you one example, and that is a doctoral thesis in Heidelberg, in my university, where they look at how general practitioners can implement prevention measures advising their elderly comorbid patients to know when a heat wave comes and to behave properly. And that doesn't only mean drink a lot, it does mean stop certain medication and get help, they get phone calls daily and so forth. So this is adaptation, this is knowing who is the risk group, an NCD person, and I know there will be heat wave. This is NCD and climate change in action together. So that's adaptation, one example. And now comes the health co-benefits, and I will be a little bit brief because time is running out. That means how do we benefit from climate policy in the health sector for NCDs? I should get one more minute because of these. So, for example, in the energy sector, every person, every climate change policymakers will tell you we should generate cleaner electricity. That reduces also outdoor pollution with all this dust. And that reduces respiratory diseases. So you have a whole list If you improve household energy efficiency, you reduce these diseases. So here's the climate policy strategy, and here's the benefit for health. If you get this publication, which should be distributed, I hope, then you can go through this in peace and go and then see the links. That is food and agriculture. As you know, if you eat less red meat, which is also good for climate change, because the red meat animals, they create a lot of greenhouse gases. In fact, New Zealand, the sheep and what the sheep produce in terms of climate gas changes is their largest emission. So if you eat less red meat, you have less sheep on the ground, they produce less climate gases, and then you save the climate, sort of. But you also eat less fat, less red meat. Have you heard from your NCD lecture, cardiovascular risk factors? So here we go. Reduce CVDs. You reduce colorectal cancer. So you see the link. Urban planning. If you improve walking, please use the bike. It's good for the climate. It's good for your physical inactivity. Here's a nice study which shows also global health, that things are very similar in developing countries and in the so-called developed world. This is London and a study by Andy Haynes, and he figured out what would it be if you had climate-friendly policies implemented in London. And he calculated the number of NCD deaths that you would spare. And here are they. Changes in the disease burden, changes in the deaths. So we are talking about thousands of deaths. You would have some more road traffic accidents because people using bikes are more vulnerable. But in the end, you would have an overwhelming positive effect in all these diseases here. Cerebrovascular, dementia, breast cancer, and so forth. The next thing is in Delhi, the same study in New Delhi in India, and you have a similar pattern. Delhi is obviously bigger, so the numbers are a little bit bigger. And I would unfortunately assume that you have more deaths through accidents from bike users. I hope you, oh well, I think you agree, Revati. But in principle, you see the same benefit. Conclusions. So there are similarities between NCDs and climate change health research approaches. You need for both long lag times between cause, risk factor, and effect. That's important for the design. You need long-term population-based cohorts to look at these effects. You have the same concept of a risk factor and population attributable risk. Climate change is an effect modifier of NCD risk. And we should teach this to our students, that here's a new kid on the block, a new risk factor. NCD increases the vulnerability to climate change. And the involvement of non-health sectors is key, like in all NCD. We will hear this from Maria, that you can't work without legislators, without food people, and here without meteorologists and so forth. And it's important for research, and it's even more important for policy response. There are mutual influences, positive, some co-benefits of mitigation reduce NCD risk. We should also tout the positive one. The negative one is that climate change increases the NCD burden, period. We should undergird it with research, but it is highly, highly likely. And NCD decreases the capability of the individual to cope, let's say, with a heat wave or with a flood. So that is the fate of the chronically ill and the multimorbid patient. Now, IUCGH is the Inter-University Consortium of Global Health, these 5 universities of Indonesia. And for them, I plea that you should include NCD-CC link, not only both separately in all graduate and postgraduate training formats, fund PhD thesis in this area, create a junior research group. You know, that is my mantra. You need these groups to generate research. And here are the 3 challenges for research. Quantify these pathways that I broadly sketched with measured effects in a longitudinal population-based approach. project climate change negative attributable impacts on NCDs till 2100, apply adaptation measures to NCD control and look how costly and how effective they are, estimate their cost effectiveness and quantify positive benefit. Basically, to undergird everything I said with hard data, and of course the translation into national policy. And that brings us back to my opening slide. Who can spot the difference? Who can spot the difference from the first slide? Yeah, the question mark has gone. Now there's an exclamation mark. So, yeah, let's do this. It's a completely new agenda. We would be on the forefront of the research frontier. And with this, I want to thank you. Thank you. No. I want to get back. Back. Can you help me? There's a thanks in, yeah, terima kasih. Thank you very much. It was difficult.
Thank you, Rhino, for the wonderful overview. And I think I would spare the audience the trauma of summarizing it again, because he did it quite well. And now we would move to our second speaker for this session, Dr. Hari. The floor is yours. Do you want to say?
Good afternoon. I would rather sit, because even if I stand, you might think that I'm sitting. Then you will ask me to stand up. Okay. Everything has been said very clearly and succinctly by Professor Sobon, so my task is easier. Thank you. Only a few hundred slides now. I think this is very famous prediction by IPCC, but let me show you a personal example. The day before yesterday, my granddaughter was born, so I'm a grandfather now. So she was born at this time, and I think in her lifetime she might feel the effect of increasing temperature, probably 1.5 to 2 degrees Celsius. So, and like Professor Swabon said, that it's not just an increase of temperature. I think it will affect many other environmental impacts, like rising atmospheric temperature, changing in climates, La Nina, El Nino become more frequent, and it's more relevant for island nations like Indonesia, where we will have a rising sea level with also rising temperature of the sea, and we will have a bleaching of coral reefs, and that would jeopardize the fish and also the fishermen, with decreasing income and also food for us, not only from fish. Now we have already felt the effect of rising temperature, because most middle class, even in Indonesia, eat tempe and tofu from soybean. And actually soybeans is plant more suitable for temperate zone, not tropical zone, but we get used to eat tempeh and tofu. And with rising temperature, it's more difficult to grow soybeans. So we have already felt the impact, the rise, yeah, the increased price of tempeh. Okay, so reduction in North Hemisphere snow cover, but in fact, what about South snow cover? Well, there aren't many people in the South because it's almost like everything is sea. But southern part is more important because under the sea we have land rather than water. So it means that snow from the south, when they melt, they will inundate Indonesian islands. They will produce more increase in sea level. So this is very relevant for Indonesia, in fact. These are examples of environmental impacts of climate change. Water resource impacts. I think now we already felt the difficulties in finding potable water, especially in Java, and water resources will deteriorate in the future. Coastal areas, we have difficulties also now with already especially the loss of biodiversities, and also we stress on our coasts, and this is because also in parts the what you call it, pakau, because we did not protect enough the coast, yeah. Mangrove, yeah. Our mangrove were cut down, a lot of them, and then we have stressful coastal areas. Agriculture impacts, forest impacts, and these are very relevant because those are the source of bread and butter of Indonesian people. The 45% of our population are farmers, and now many national revenue comes from forest. So we will have difficulties due to the climate change. That's why adaptation is important, and also I think mitigation is even more important when we are talking about health impact of climate change. I think this is the same, or in fact simpler figure. I do not include the adaptation and mitigation. A very old slide, and this is maybe newer. The motivating influence could be from environmental conditions, from social conditions, and we are also talking about health system situations in Indonesia now. Those will produce impacts on health and healthcare related to climate change. Again, the same studies. Yeah. Nombre de décès journalier à Paris et température minimale. The number of deaths journalier every day, yeah, in Paris, and we see that by increasing the temperature in June until August, we see that more funeral, more mortality related with heat wave. So, and Professor Sobon already talked about that. It's not not only in France, but also in Africa. So I think it's already explained also. Climate change and respiratory health will have increased number of deaths and acute morbidity to heat waves, cardiorespiratory events due to high concentration of ground level ozone and particulate matter, 2.5 micron. Change in frequency of respiratory diseases from transboundary long-range air pollution, and we have already that, forest fires, aerosols, and we have disruptive forest fires to our neighbors, to Singapore and Malaysia. That's very shameful. We have altered spatial temporal distribution of allergens causing allergies, and of course some infectious disease factors. This slide will show that based on models, studies by Italian researchers, that the relative effect modification index means that there will be an increased risk of cerebrovascular diseases and respiratory diseases and also chronic pulmonary diseases because of increasing temperature from 20, comparing 20 degrees to 30 degrees in Italy. So, although it's quite modest, the rate increase is only 2.4, but for respiratory, pulmonary disease, I think, 1.2, 1.2, and 1.8. But those are significant. So statistically significant. I think this deserve more studies or more models here in Indonesia. For asthma, I think we will have an increase of asthma events due to decrease temperature range and relative humidity range, of course in some areas in Indonesia. We have already experienced droughts due to extreme weather, and this also related to pollution of particulate matter, increased concentration of biogenic sources of particulate matter of such as wildfires and dust from dry soils in agricultural area. We have already experienced increasing frequency of floods, injuries, exposure to toxic pollutants. Other than infectious diseases, we have also exposure to toxic pollutants causing diarrhea and respiratory problems. Of course, excessive rainfall facilitates entry of bacteria to human sewage and animal waste, so that we will have more diarrheal diseases. Longer term flood effects, we will have malnutrition because of crop loss, mental health disorders from stress of flood related problems, of course social disruption, depression, and other mental illnesses mentioned by Professor Sobon, and I agree, I couldn't agree more that mental health is very much part of climate, the effect of climate change. And I also agree that malnutrition is also an important non-communicable disease, because if we see this slide, under 5 children, undernutrition played 33%, one-third contribution to child deaths. So I think for us, this is a very significant factor related to climate change, because that would be threatened food security, and of course we will have more malnutrition or undernutrition, precisely. We will have temperature stresses, water stresses in countries near the equator, and including Indonesia. I don't know why it's milder in Indonesia, but I think it's maybe more than shown here, the effect due to water stresses, especially in Java, because I think this is for nationwide, but Indonesia is very large, yeah? And a lot of variation in the effect of climate change, especially related to water scarcity, water quality. In Java, in 5 years, 10 years, we will have problems with water, with clean water. Yeah, co-benefits, I think, has been explained very well by Professor Sobon. We will prevent 800,000 annual deaths, 1.5 million from indoor air pollution, and people here are still smoking, so a lot of them in Yogyakarta, because the government owned cigarette factories, and also the vice government. Yeah. Injuries from traffic accidents. So this would be the co-benefits. We can mitigate the emission. So in summary, these are activities related to climate change adaptations, food security improvement, more diversification of food, environmental health capacity building, healthy public policy and development, safe drinking water, health action in emergencies, better preparedness dealing with emergencies. And we will show you that Indonesia is beginning to enter the so-called lower middle income countries. Maybe, hopefully, will be the upper middle income countries very soon. But it shows that more proportion of NCDs are going along the way when we improve our income to better situation with regards to national income. Males and females the same. So I think because we have the background of high proportion of NCDs, with climate change we will expect that these becoming more risky, more risk will be the impact of climate change. We will have primary, secondary and tertiary adaptive measures. Primary is just like prevention in public health. Although it's adaptation, not mitigation, but we will have also primary adaptive measures to prevent the onset of disease arising from environmental disturbances, and we will improve our surveillance system so that we can rapidly initiate actions in response to early evidence of health impacts due to climate change, and tertiary adaptive measures to lessen the morbidity and mortality, to improve our response, for example, and recovery from disasters. We have a lot of experiences with disasters in this country. Some are major disasters and some were local disasters, but still every year we have disasters. So if we can improve our actions to lessen the impact of morbidity and mortality, that would be very helpful to the people who faced climate change. I think this is the Indonesian government already include some environment and disaster management, but not the top list, because I think the concern now is corruption, bureaucratic reform and good governance, education and health. But here, health, I think, is very relevant to climate change, what we are talking about today. But food security, energy, of course, infrastructure, of course, as a part of adaptation and mitigation, we need to improve our infrastructure. Investment climate is not related with climate change. Investment climate is how the government facilitated investment to these countries to improve the income of the people of the nation. Okay. And we are aware fully that the adverse health impacts will be greatest in low-income countries. Indonesia may be still low income, although now we call ourselves middle-income countries, but still in terms of climate change, since our location, our being an islands nation, we will face a great deal of burdens due to non-communicable diseases because of climate change. Thank you.
Thank you, Dr. Hari. And now I will open the floor for questions. I think we should spend about 20 minutes taking questions and then proceed for the lunch. So, any questions, comments? Yeah. Okay, may I request the people who have the questions to please come forward, introduce themselves, and then address the question to one of the speakers, or both.
Sorry, I'm bad with technology. My name is Lamia. I'm part of the Social Determinants of Health Winter School. I'm from Egypt. My question is for either one of the professors. It would be about, you were talking about how there was a symbiotic relationship between health and climate change. But I'm wondering if there's not also a lot of conflict, especially when Professor was talking about how the mangroves were taken out. I would understand that that would be for control of malaria and dengue, but then it causes other problems with climate change in the coastal areas. So I was wondering if you could just talk a little bit about conflict between climate change and health. My second question would be whether for Professor Sawa, if which in your opinion is more? I mean, I couldn't understand from the graph. Maybe I was just one synapse behind you. Climate change has a greater effect on communicable diseases or on non-communicable diseases? Because I thought it was on communicable from your presentation, but would that be because it was just more quantifiable? Thank you.
Maybe we collect 2 or 3 questions. Anybody else who would like? Please.
Thank you for the opportunity. My name is Joseph Romanado. I will ask to Professor Brown, what is the good consequences of climate change to the NCD? Because from your presentation, we just heard the negative effect of the climate change, and now I'm asking what is the good consequences of climate change to NCD? And the second question is, which is the condition that more impacted by climate change, the communicable disease or the non-communicable disease? Thank you.
Maybe one more question, one more person who has, please.
Good afternoon for all. We know that we live in sophisticated technology today. Discuss about the climate change. It is very special for me from environmental health program from Gajah Mada University. I want to ask to Prof. Sauben and Prof. Hari. How far the impact of radiation from communication technology, such as handphone, that influence the climate change. Okay, this is, thank you.
Sorry, could you repeat the last sentence? I didn't understand your last sentence. The question. Can you repeat the question, please?
Okay.
If you could say in Indonesian, I will translate.
Okay, yes. I'm sorry, my English is very not good gitu. Mungkin gini, untuk Prof. Hari dan Prof. Sauben, pertanyaan saya, seberapa jauh dampak dari radiasi teknologi komunikasi seperti handphone dan sebagainya dalam mempengaruhi perubahan iklim gitu?
Yeah, I think this is a very good question. How far is the impact of radiation due to mobile phone technology to the climate change, I think.
Okay, thank you, Prof. Okay.
Thank you. Do you want to take the one with the conflict between climate change and health? Adaptation. Yeah. You wanna, and then I take what's more important, communicable or non-communicable. Yeah. And you want to take the one with the radiation of the cell phone? Please. You first. Okay, we just divided I gave him the most difficult question to answer, particularly the last one. So let's start with the 2 questions were on the issue, will there be more communicable or infectious diseases? Our current thinking is that non-communicable will be more. If you include malnutrition and then asthma, cardiovascular, stroke, and all the others. And mental. If you exclude them because you only look at 4, then the picture will be different. But I don't see any reason under this perspective why we should exclude them. And it also depends on the country. I mean, if the country has very few infectious diseases as a little problem, then you can't expect climate change to have a large impact on infectious diseases. And as you've seen, your country is already 60% of the deaths are already NCD. So both because your distribution of the epidemiology of diseases, I would expect, and because of the generic force that climate change has on NCDs, I would predict that your country suffers most from NCDs as a result of climate change. But again, I must say the evidence is thin. In the IPCC, we grade the evidence with which we make statements, because then the governments read it and say, how can you say that? There's only one paper. And we do this in a very interesting scale. The one is the consensus between the papers that we read. So are they agreeing? We call this agreement. So if you have two papers and they agree, you have a perfect agreement, but you only have two papers. And that's the other criterion, which is the robustness, the amount of good quality evidence. And here we have very little, I must say. So this is mainly what I'm saying, this NCD communicable disease, mainly an expert judgment plus the literature that we have. So with this caveat, I think you wanted to take the one on conflict. The first lady who asked, is there a conflict between climate change policy and health policy?
Yeah, I think the example is when we cut mangroves, it means that we prevent malaria transmission. I think this is not quite true, because especially malaria in the coastal areas is transmitted by Sundaikers, and Sundaikers live in the swamps and I don't know exactly in English, but this is a mix of salty water and fresh water. Brackish water. Thank you. Yeah, brackish water, and that's the breeding places of Sundaikers, and it's nothing to do with mangrove, and that's why we try to prevent elimination of mangroves, and we try to replant mangroves in northern coast of Java, because this is very important to protect our coastal areas from inundation of the sea, increasing sea level, and also we protect also, in fact, the coral reefs. Yeah, coral reefs. So mangrove is important. And dengue is transmitted not by Anopheles, but it's transmitted by Aedes aegypti. Aedes aegypti is usually live around the house. Yeah, around the house, not in the coastal areas, not especially in coastal areas we don't find Aedes aegypti. In the field we might find Aedes albopictus, which is more effective in transmitting dengue in the laboratory, but not in nature. So we are not worried about Aedes aegypti or dengue related to coastal areas, or especially related to mangrove, yeah, the elimination of mangrove. So I think the environmental policy to replant mangrove is very good. It doesn't transmit malaria or dengue. So that's the point. I agree to the questions that some areas might benefit from climate change, from global warming. If we look at if you remember the slide shown by Professor Sauben in Africa, yeah? Increasing temperature causes increased mortality among elderly. But if you look at the other side, yeah, decreasing temperature also increase mortality. So global warming will improve colder area, yeah, improve the temperature, ground temperature in colder area, and that's prevent death among the elderly due to cold weather. So there are some benefits of course from climate change, but proportionately it's very small. I think that's my belief, and also based on the predictions, we will have more problems than benefit out of the climate change. I think maybe and with regard to radiation, I think this is a very good question. We know that now everybody, even people who help me in my household, they use mobile phone, yeah, mobile phone. They own not only one mobile phone, maybe 2 or 3, because it's inexpensive. So, and it radiates electromagnetic field. But how it relates to climate change? I think it's more appropriate if we ask about more sunshine while we are using ozone depletion. Ozone, not ground level ozone, but what you call it? Tropospheric ozone? Stratospheric ozone, yeah? Because there will be holes in stratospheric ozones because we use CFC, yeah? Chlorofluorocarbon. We use air conditioner, and we still use that, although we ratify the Montreal agreement that we have to change our depleting materials, ozone depleting materials, but we still use them. And the government try very hard, especially in Jakarta, to put the regulation into practice and to enact the regulation so that we will reduce the use of depleting materials. But I think this is very important, because when we have more sunshine, direct sunshine, then we will have more ultraviolet, yeah, which will cause more cancer, more skin cancer, and also cataract, and also some disruption in our endocrine system, more diabetes. So I think this is more important if we consider climate change, while the use of handphone or mobile phone, I think it needs more research, whether it causes brain cancer, some studies, but it's still inconclusive to my opinion or my readings, based on my readings. Thank you.
Yes, I agree. I am not aware of any conclusive evidence that using mobile phones causes health hazards. I challenge you to convince me of the opposite. And I am not aware of any evidence that it has any link with climate change. I don't know, maybe you can elaborate what you thought would be the pathways. I could, of course, think of mobile phones as a wonderful tool to adaptation, to chronic care, and mobile phones are a blessing in outbreak reporting, in all sorts of health-related communication. So I'm a big fan of mobile phones, not only personally, but also professionally. I wanted to give one example. The First Lady asked for the conflict. There's always conflict if you have different policies, of course. For example, as a health person, you would want to have in every factory of this country climate air conditioning, yeah, and in every household, and in every hospital, and in every health center. Of course, that is good for health, but it's extremely bad for the climate. Because assuming that you use fossils or as long as you use fossils for creating that, generating this energy, this will lead to enormous emissions. So here is a conflict. Of course, it must be solved creatively. We should all go to renewable energy, and then it doesn't matter how much you use. But as long as we don't, there's a clear conflict. That is one example. I wanted to get back to the question, is there anything good that climate change does to non-communicable diseases? I must tell you, I couldn't think of anything, if you can help me. So there are, on infectious diseases, you can argue if things get too hot for some vectors, that can happen and so forth. But in non-communicable disease, I only see as a good message that not climate change is positive for an NCD, but the climate policy is positive for health. That is the famous co-benefits. So if you do something for improving the climate, like reforesting a city like Jakarta. That's not only good for health, but it's also good for the climate. So to get more of these synergies, I think that is our goal. This also goes in the other way. For example, if you indoor cooking, and the health hazards of indoor cooking with biomass was one of my research interests a while ago. And as you know, more people, particularly women and children, die of indoor air pollution than they die of outdoor air pollution. Although in the press and in the media you only see, oh, the bad circulation outside. This is called the silent epidemic because they have no voice. Literally speaking, these women, they're poor, they are marginalized. And then now there's been this movement to put clean stoves or to put LPG. When LPG is a climate greenhouse gas. So you have, again, a conflict. But now they found that these women, while they cook with biomass, they produce soot called black carbon. And since 5 years we know that this soot, this black stuff that is at the walls and also at their lungs, unfortunately, that is dispersed to Antarctica, to Arctica, to the Himalayas, and rains down on the white surfaces there, on the snow, and reduces the reflection of the energy that comes down from the sun. So even that poor lady who cooks and intoxicates herself and her family, she is now also a climate culprit, if you allow me the term. She's contributing to climate change by creating these black carbon particles. Here's a perfect synergy, a perfect co-benefit. Get clean stoves and then reduce the black carbon at the same time. If you can do it with solar energy, it's perfect. If you do it with LPG, it is not perfect, but it's better both for the climate, reducing black carbon, which is very bad, and for the health of that family. Did we answer all the questions so far? No protest?
Do we have any more questions? Yeah, please. You can answer it straight away. Each question.
When does it finish?
Yeah, we first.
Good afternoon, everybody. My name is Muhammad Asrullah. I come from the Nutrition and Health Gajah Mada University. I want to ask for Mr. Prof. Rhino, right? Prof. Rhino. According to your slide that the one effect of climate change, regional and globalization is talk about the food security, and food security has a relationship with malnutrition. In your slide, malnutrition is increased, right? And then in the second speaker, Prof. Hari already explained about the national priority in Indonesia, especially food security is the sixth priority in Indonesia, especially. I just wondering that how about in Germany? How about in Germany about the food security, and how about the policy in Germany to reduce or to minimize effect of the climate change, especially in nutritional side? Thank you very much.
Thank you. First, thank you for the question. It's a very important one because we didn't talk a lot about malnutrition because we thought malnutrition is not an NCD. It is a real problem, and I'm very glad that Indonesia has this as a sixth priority, which is also now a climate change priority. Because climate change, like it or not, will decrease on balance the harvest yields of all cereal crops, including, which I didn't know, but I learned today, soja, for example, which is a major staple here in this country. So, of course, you cannot say less food, more malnutrition. It's not as simple as that. There are markets, there are social factors, you can purchase food and so forth. It's complicated, but and we are trying to set up a research project on this. But everything else equal, there will be a decisive impact, and what to do Now that's a very good question. The first question is you have to say this loud and high at the climate conferences to stop greenhouse gases increase. That's very important. Because you can adapt until you're blue in the face. If this is not stopped, then it's like you have a house on fire and you just put out the furniture without stopping the fire. You need to go to the root of the problem. That's climate policy. The other thing is make your food system more resilient to food insecurity. And that is a very complicated agenda, which means diversifying, introducing new crops, a better warning system for bad harvests, better stocks, and food transportation within the country. That's beyond my field, I must say. But there is a close contact usually between the climate community, meteorological community, and the food security community in the country. Now, you ask me about my country, I must say I don't know. I don't know. I have to look it up and we'll give you a feedback. I don't know. Since we are buying most of our food, we are most vulnerable to market prices, to market if the prices go up and down. But I don't know of any specific policy that the German government has implemented on this. But I will look it up for you. Thank you.
So I think with this, I would like to thank both the speakers for the wonderful presentations and the audience for their patience. And I think the take-home message from this session for all of us would be that climate change is not just a risk factor, but also an important effect modifier when we are trying to look at the health impacts. And the other thing is that quantifying the attributable risk factor from climate change to the health impacts is the most important thing. And like we have seen from the morning sessions and even now, that the evidence or the quantified values for this relations between non-communicable diseases and climate change is missing. And I think this is what we should focus on in the next 10 years or so. And of course, the importance of having long-term data for being able to say something on this. And last but not the least, the importance of co-benefits, of mutual co-benefits of intervening with adaptation and mitigation strategies. So thank you very much, and I wish you all a very nice lunch break.
Thank you, Prof. Rainer, Prof. Hari, and Dr. Revati. Let me underline one sentence. But climate change has a big impact entirely to NCD. And so keep attention to this issue, because later on we have a presentation how to prevent and control NCDs. Before we proceed to our next agenda, for the next 45 minutes, we will have a lunch break. You are all welcome to enjoy the meals and drinks which have been served outside this room. We will continue in the next session, 45 minutes from now. For the additional information, the poster will be placed in surrounding of the lunch venue. And we please, for the Muslims who want to pray, there is a mosque in front of this building across the park. Thank you very much and enjoy your lunch. Thank you.